Good morning, everyone. I'm Deborah Garlick from Henpicked, and welcome to our Lunch and Learn. This week, our subject and focus is on early menopause. It's a subject that we're very passionate about at Henpicked, and I'm delighted to introduce Mr Nick Panay, who's a consultant gynaecologist for Queen Charlotte's and Chelsea Hospital, and also for Hormone Health. Now, we know Nick very well. For those of us members of the team that are on this call too, that are Henpicked Menopause in the Workplace trainers, we consider Nick to be the leading expert in the UK on menopause, and we revere Nick Panay. And for us, one of the questions that we often get from women is, I'd like to talk to a female GP, or I don't want to talk to my line manager because he's a man, about menopause. And Nick, you know, it's not going to escape anybody that you're a man. And I think the answer that we often give when we get that question is some of the leading experts in the UK are male, and it's not a matter of male or female in terms of expertise. It's more a matter of how their level of knowledge and their passion around the subject. So it's an absolute delight to welcome you today, Nick.
Thank you very much, Deborah. It's a pleasure to be with you.
And we're going to jump straight in, Nick, because my colleague Sally is behind the scenes. So for anybody who has any questions at all during this session, please do use the Q&A function, and Sally will come back on towards the end of this session and read your questions out anonymously if you wish. So Nick, we're going to jump straight in then and look at what is early menopause and how is it diagnosed?
Thank you, Deborah. Well, early menopause occurs when the periods stop before the age of 40. That's referred to as premature ovarian insufficiency. It affects about 1% of the population, but a recent survey from Sweden suggested it may be higher than that, around 3%. Early menopause itself is when menopause occurs before the age of 45. And that tends to affect around 10 to 15% of women. So it's actually a more common problem than people realize. And that's why it's important that we fully understand what causes it and how best to manage it.
It's interesting that you say that it's probably higher, because I know our experience when we're running training sessions on menopause is, you know, I experience this, that I have a room of 50 women and several of them will come up afterwards and say, actually, my period stopped while I was in my 30s or in my 40s, and I didn't really do anything about it.
Yes.
It's got to be significantly higher than the current figures do say.
Well, even if we put it at 1%, that would, in the UK, affect more than 1 million women potentially. But I think what's happening is that women are not presenting with this problem, maybe because they don't think that an irregularity of their periods is potentially due to early menopause, particularly when they're very young. We often put these things down to stress or changes in weight or other conditions like polycystic ovarian syndrome. But sometimes women do present to their doctors and perhaps they're not investigated early enough. You know, again, the doctor says, well, it's likely that your periods will return. So there's no need to do tests at this stage. So I'm campaigning, if you like, for greater awareness, if you like, of menstrual health and the possibility for these young women when they present with periods. And we say typically if the periods have stopped for 2 or 3 months, and they should be investigated. And, you know, it's quite simply done as a blood test, and that should be done sooner rather than later.
That's interesting. And I guess as well that for some women, if they're taking birth control, they may not actually realise what's going on for some time.
Well, that's right. And particularly now that birth control pills are used perhaps for longer than they used to be. And the first realisation that there's a problem is that the woman comes off her contraceptive pill and finds that her periods haven't returned. And we used to say, post-pill amenorrhea, we used to say that's because of the pill itself. We now realize that it's not because of the pill. It's usually because the pill was underlying a masking or masking a problem rather than causing the periods to be delayed in returning.
And you mentioned it being diagnosed with a blood test. We know the NICE guidelines say for women who are otherwise presenting healthily over the age of 45, tests aren't required. But what would be different for early menopausal women? What would they have?
I was part of the NICE guideline development group, and the reason we made that recommendation for women over the age of 45 was because if you have somebody who presents with hot flushes and sweats and is over the age of 45, the likely diagnosis is menopause. But when you have women presenting earlier than 45, and particularly before the age of 40, the diagnosis can be more difficult to make. There may not be the classic symptoms of hot flushes and sweats. There may not be any symptoms at all. Or the symptoms may be of brain fog or mood swings or subfertility. And that's where it is indicated in that instance to do the blood tests, unlike the situation with natural menopause.
Okay, thank you very much. And thinking about why it's important for women to be diagnosed, why do you think it's so important to get that extra support?
Well, the condition itself has a profound effect on the sufferer. It's not just the loss of hormones, it's the loss of fertility. And that can have a significant psychological as well as a physical impact on that individual. And it can potentially affect a partner, the family, and also the workplace. Her place in the workplace may be affected by symptoms that are out of her control. And this may not be fully understood by her manager or colleagues working with her. So I think we all have a responsibility to be aware of the potential for this sort of problem and provide adequate support where we think that somebody is going through this problem.
Are there greater health risks for women who experience menopause earlier?
So early menopause results in a loss of estrogen. The loss of estrogen can lead to hot flushes, sweats, mood swings, loss of sleep, urogenital problems, so vaginal dryness, pain on intercourse. So it can impact significantly on quality of life. But also in the long term, if left unchecked, it could potentially lead to an increased risk of osteoporosis, cardiovascular disease, and it's even been linked in the very long term with a potential increased risk of Alzheimer's as well. So for all these reasons, it's important that we make the diagnosis early and we start treatment early. And treatment is very straightforward, either with the pill or with hormone replacement therapy. This should be continued at least until the average age of the menopause, which is 51.
You mentioned birth control and HRT there. That's one of the questions that we tend to get from women around, should I be taking birth control or HRT? How would you differentiate?
Well, it may be that individual still does not wish to achieve a pregnancy, in which case birth control would serve a dual purpose there, contraception and also hormone support. But our preference for those women not seeking birth control is to advise them to use hormone therapy, where the hormone therapy mimics as closely as possible the natural environment, hormonal environment that would have been present, because there's evidence that seems to be the best in terms of restoring quality of life, but also protecting the bones and the cardiovascular system.
And that's interesting. One of the things that I think is starting to change now is the reputation of HRT. And because of course there've been so many scares, and we often hear women saying, I don't want to take HRT because I don't want to get breast cancer. That's starting to change, isn't it?
Very much so, and I think that we have to be very careful that we don't extrapolate the problems that have been talked about of HRT with natural menopause to the scenario when we're replacing hormones with premature ovarian insufficiency or early menopause. Because in that scenario, we are literally just restoring the natural hormonal environment of women. And we don't think, for instance, that that increases the risk of breast cancer over and above what the risk would have been if the ovaries were working normally. As I say, we're merely restoring the natural hormonal environment. And in my experience, if you get the hormone therapy right, side effects are very few, but the benefits are absolutely great, both in terms of quality of life and also primary prevention of the problems that we've talked about.
One little question, it's not necessarily to do with early menopause, but it often comes up during our sessions, is you can only take HRT for 5 years. And I think sometimes women with early menopause actually worry about that even more.
Yes, we need to get away from the 5-year or 10-year mantra, and it particularly does not apply to women with early menopause. Women with early menopause are advised to use hormone therapy, as I say, at least until the average age of the menopause, whatever the length of time that is. And actually studies have shown that the longer these young women continue with their hormone therapy, the lower the risks of fractures, the lower the risks of heart problems, better cognitive function, better quality of life, better sexual quality of life.
Excellent. What's the youngest woman that you've met, Nick? I know the youngest woman with early menopause that's written an article for Henpicked was 17 when she experienced menopause, which for me was a complete, I would never have conceived it.
No, unfortunately, we do see these very young women, teenagers, 16-year-olds, whose periods haven't started. What we refer to that as primary amenorrhea. So basically, either they were born without functioning ovaries, or the ovaries didn't have eggs in them. And unfortunately, yes, it can happen in that young an age group. And you can imagine that the physical and emotional support that they will require at that stage of their lives is immense.
Absolutely. And I know that the first time I saw you speak was at the Daisy Network annual conference, a fabulous charity that supports women and partners, because when I went to that conference, the thing that struck me most was that the early menopause doesn't necessarily just affect the individual. It does affect the relationship with the partners. It could mean that they were thinking of starting a family, and now they know that the likelihood of them having a family is very low. So that was a wonderful environment in that conference for people that had the shared experience of early menopause to come together and listen to experts like you to help them understand what they could do. I know it's something you're very passionate about.
Yes, I've been a patron of Daisy Network for many years, and I think the work they do is fabulous. What they aim to do is basically make women with premature ovarian insufficiency, early menopause, feel supported. And there are many women with premature menopause working with Daisy Network that provide this networking, this support for other sufferers, so that they don't feel that they're the only ones going through it, and so that they can seek advice and support and learn from others' experiences and take the good and discard the bad aspects of this problem to try to optimize their quality of life and well-being in the long term. And they also put on these meetings as well, where sufferers and their partners come to learn from experts in the field who are talking about the latest developments in the field.
Absolutely. I know the first time I went, it was when I was doing research for the book, which has got early menopause in there. I have to say, I sobbed all the way home. I met so many people who had been severely impacted, and I think my takeout from it was they were struggling so much. They you know, their life had been completely changed, yet they were so brave and they were so supportive of each other, that I found it very, very touching. So for anybody that's on the call, we will send you information off the Daisy Network, and of course, Nick, your own practice, Hormone Health, if you don't mind me sharing your details. And I'll just ask my colleague, Sally, if she can pop on and let us know of any questions so we can have a bit of a chat. Nick, while we're waiting for Sally, how are you finding all of the Zoom consultations? Because we can all access you now, can't we? We can all get a consultation with you in your Harley Street practice by going online and doing it through Zoom.
Well, both in the NHS and privately, we are conducting telephone consultations as a norm now, and introducing video consultations as well. And we were only saying the other day that if this had happened 20 or 30 years ago, we would have all been so much more isolated. But I think what this has helped really is to accelerate our use of technology. It's still not perfect, but it is a great opportunity to consult with our patients, and also to have conferences as well online. So, you know, the clinical work that we do and the science doesn't stop.
That's great. And when you say about the consultations, one of the questions that we had from one of our community at one of our last sessions was, she was saying that I'm not going to see my GP because there's too much going on with COVID, and I'm sure menopause isn't a priority at this time. But that's not the case, is it?
The most important thing is that we remain as fit and healthy emotionally and physically, so that if we are affected by COVID, that we are able to cope with it. And so I think it's even more important now to maintain your general health and well-being during this difficult time. And also when we come out of it, to hit the ground running, as we say, so that we're in top form to then enjoy our long-awaited holidays.
Fabulous. Thank you very much. Sally?
Yeah, so we had loads and loads of questions. Everyone's been keeping me very busy, which is great. In particular, questions around the choice between taking the pill or HRT when you're going through early menopause, and just kind of a clarification on what would be the best option for a woman.
Well, as I was saying earlier, I think the pill early on, particularly for younger women, may be a good practical choice. They may feel most comfortable being on the pill. It's what their peers are using, their friends. And so I'm happy to support them in using the pill initially. And I'd rather they use the pill than use nothing at all. And they will get benefit from the pill. One of the things we must remember is that the pill is normally taken with a 7-day break, or with some of the more modern pill regimens with a 4-day break. But with this condition, if you take a break from the pill, sometimes there can be a resurgence of symptoms. So I usually advise women with premature ovarian insufficiency or early menopause to take the pill continuously. As time goes by and contraception is not an issue, or perhaps you know, the diagnosis has sunk in and people have had time to process it, and actually really want to do everything they possibly can to optimize their long-term well-being, then we gently move into the hormone therapy era. And with the modern gels and the natural bioidentical types of progesterone, side effects, as I mentioned earlier, with hormone therapy are rare in my population. Their hormone therapy is usually very well tolerated, and they usually do very well with it. And we mustn't forget that sometimes it's not just estrogen and progesterone, but sometimes we give a little bit of testosterone as well with the hormone therapy. because that can help energy and libido. And we know that testosterone levels, as well as estrogen, progesterone, do decline with early menopause. So that's, again, something that we're working on in the guidelines that we're presenting to the health authorities, etc., that this needs to be considered in the consultations as well.
Excellent. And one of the questions around you saying that HRT is generally well tolerated, for those women where it's not well tolerated, what other advice would you give, or what other treatment options are available?
Well, look, sometimes we don't get the HRT right the first time, you know, and it can take a little bit of work to find that the right preparation for the right individual. But I believe that if we give it due care and consideration, that we can find a hormone therapy regimen that suits every single woman out there. But listen, there are occasional exceptions where hormone therapy can be problematic, and we do look at alternatives like the pill and non-hormonal options as well. We may consider a complementary therapy, for instance, derived from red clover or soy. But the problem with the complementary therapies is we cannot guarantee adequate protection of the bones and the heart. So in the rare situation where we consider alternatives rather than standard hormone therapy, then we do recommend close monitoring of that individual. And we do blood tests to look at cholesterol. We do bone scans to look at bone density and that sort of thing. But those are the sort of things that we would do anyway with early menopause, just to make sure that people are doing well. I'd just like to mention that we are planning a big study coordinated by University College London, Melanie Davis, the Clinical Trials Unit at Nottingham. It'll be a national study looking at pill versus hormone therapy, looking at quality of life, bones, cardiovascular risk markers. And it's going to be a long study, 5 years, but then hopefully with an observational arm to that continuing much longer. So that will give us even more answers than we have at the moment, because currently the data that we've got are from smaller studies.
Excellent. Thank you very much.
We had a question about the new spray, Nick.
Yes.
Because people seem to think that HRT is a banner product and it's just one product, but you're talking about tweaking it. And there's what, 70 different preparations. And there's a new one, isn't there? There's a spray that's coming out.
Yeah, I always say the wider the armamentarium, the wider the weaponry, the more tools, the more weapons, if you have to deal with the problems. And it's always a deep joy to me when I see a new preparation come on the market, and particularly one which favors the delivery of estrogen through the skin, because we believe by avoiding going through the liver, that's the best way to minimize side effects. And so we've got gels, we've got patches. People will be aware that there have been supply issues, particularly with the patches recently. And now we've got a spray estrogen, which can be applied to the arm, 1, 2, or 3 sprays per day. We must remember, though, that that's only the estrogen part of it, and that we still need to use progesterone with that. But it's great that we've got that as an option as well. And I find in my younger patients, they prefer not to wear the patches so much, but to wear something which is actually not visible.
Yeah.
Which is more discreet, if you like.
Well, we look forward to that. So that'll be in about 5 years' time, we'll know the difference between the two. Between
pill and HRT, yes.
Excellent. Any other questions from you, Sally?
No, I mean, there are a lot, but obviously we don't have time to cover everything today. So I'm just adding a note on to everyone just to say we will be putting together an article on the Henpicked site summarising everything that we've been covering today, and some of the other questions. That a lot of the themes that have come out have been around HRT and the pill as a choice, and other alternatives, and say you've covered all of that, which has been fantastic.
Thank you, Sally. So what we'll do next then, we'll send everybody who's on this call today, thank you very much for joining us. We'll send you a newsletter We'll include an article from the notes that we've taken and looking at the Q&A from Sally and making sure, Nick, if there's any that we don't think we've answered in that in this session, we'll talk to you about that. And you can watch the replay again. We will also send you information about the DAISY network, because if anybody is experiencing early menopause and hasn't heard of them, please do join them. Please do tap into those resources. And Nick, with your permission, we'll send people out information about hormone health as well. So you can get in touch with you if need be.
Yeah, we've just had a couple of people asking whether they can get involved in the study that you're doing, or how they hear more about the study you're doing.
So if we could take their details, they will need a referral from their GPs.
Okay.
Because of the COVID situation, things are on hold at the moment, but as soon as we know when we've got a start date, then we'll be in touch with them.
Brilliant, thank you very much.
Pleasure.
So if anybody wants to get involved with those, in the first instance, shall we say, get in touch with us at Henpicked, contact@Henpicked. I'll put a link in that so people can follow up, and we can make sure that they get in touch if needs be. But other than that, Nick, it's been an absolute pleasure, and I look forward to seeing you again. And if anybody's got any further questions, do feel free to get in touch with us. Thank you very much.
Wonderful,
Thank you, and thank you to Henpicked for hosting this.
Thank you.